question.
All right. I have a question for, you talked a little bit about AV valve repair on the single ventricle patients, and I was just curious as to valve replacement for those patients, either pre or post Fontan, and is that a viable option? Are you seeing, the typical regain of function and those kinds of things that we kind of see with valve replacements in general?
That's a institute-specific question. Sometimes you can have valve replacements that are performed. The problems that we have are the same problems we've discussed in other diseases. How long are those valves going to last? What type of valve are you going to put in? Are you going to put in a mechanical valve in someone who's already at risk of a thromboembolism? At what level would you keep their anticoagulation at? They're at increased risk of bleeding. They have all these other complications. So they are done at some institutes. I don't have any true data. I don't know if any of the other people have true data on that. But, it's this is a ongoing learning experience as we have more and more patients with these problems arising.
Yeah, and I think the other thing to remember is you're talking about putting a mechanical valve in a 3-year-old, which is not that straightforward to get a valve in there that's going to be big enough to last them a lifetime. And also, we do Coumadin in 3-year-olds, but it's certainly not the easiest thing in the world. In arterial switch patients with PM is pacemaker? What is PM, do you think?
I'm guessing pacemakers.
What is the cause? What's that? Pacemaker. Gotcha. What is the cause of an incidence of lymphatic system problems in adulthood? What imaging is preferred for diagnosis? So, I'll be honest, I guess I'd say the answer to that is I don't know, but I'm going to have to assume at least some of that would be if they've had pacemakers for a long time, that venous obstruction up in the innominate vein and that potentially impacting thoracic duct drainage and that kind of thing could lead to some lymphatic system dysfunction. I will say that I'm really thankful that I haven't dealt with that. And as ideas as far as what imaging, I think we're pretty quick to go to the cath lab just to look for venous obstruction, that's for sure. I think more and more MRI, when it comes to lymphatic imaging, MRI is becoming pretty good at that, and I might look at MRI. Do y'all have any?
And you can do true lymphangiograms, which are not done at a lot of institutes, but there are some institutes where you can directly get into the thoracic duct and do imaging.
Do you guys have any experience with this?
I was thinking not so much about arterial switch patients for that, but certainly, maybe I'm not understanding the question fully, but certainly in Fontan patients who have protein-losing enteropathies, and we don't see plastic bronchitis in adults, but protein-losing enteropathy certainly represent. University of Pennsylvania has some experience of doing direct lymphangiography and lymphatic interventions as a treatment for protein-losing enteropathy in Fontans. In arterial switch patients, I have not seen that either. I don't know if anybody else has.
Go for it.
When do you trigger transplant conversation in Fontan patients?
Wow, that's a good one.
That is a very good question. So, the problem that you have with doing transplant in Fontan patients is that is another palliation that you're doing. You're trading one set of problems for another set of problems. However, in saying that, any patient I have that has PLE, I immediately send them for transplant evaluation. If they are having significant dysfunction to the point where it is New York Heart 3 or above, I send them for an evaluation for a transplant because we know that we're limited in our other abilities to do things. And then the final thing is hepatocellular carcinomas. The treatment of that is you have to get a new liver. And if you're going to get a new liver, you have to relieve the inciting problem there, which is the Fontan physiology, so you would do a heart and liver transplant on there.
Yeah, I think this is really one of the hardest problems because we have, I mean, I think we all take care of patients who would have kind of transplantable problems, for instance, protein-losing enteropathy, which we were always kind of taught had a 50% 5-year mortality, but the reality is a lot of these patients with good therapy can live for a long time. And yeah, maybe you could have transplanted them, but there's a good chance that they would have been dead 10, 13 years later just from transplant problems. And in fact, they're still alive and doing okay. But then we reach that other side where when we actually do come to transplant them, their liver is far enough gone that we're having to make those really hard decisions about liver transplant, whether we need to do heart or heart-liver transplant. So I think the right answer there is I struggle with this a lot, when to refer for transplants. I'm kind of innately pessimistic because I've found it very hard to get these patients transplanted. I don't know if everyone shares that, but there's this pie in the sky of, okay, well, and I think the other thing with the Fontans that we didn't really mention is that a lot of the old data that Ryan showed, it doesn't have any hypoplast in it. And so as these hypoplastic left heart syndrome patients become adults and kind of start entering into this data, this is going to become a huge issue when to transplant these patients. And it's a very, very hard decision when to push towards that transplant, and it's hard to get them done.
I was going to add that I think this is a Goldilocks, is it too hot or is it too cold phenomena where you have to, it's a challenge to find the right timing of when to refer. But I have tended more recently to refer earlier, not necessarily for the transplant, but to get the decision-making as more of a group decision-making where I don't feel the onus is just on me as the ACHT provider to decide now is the time. But if you're starting, to start seeing a heart failure, pulmonary hypertension, transplant specialist early on, so it can be more of a collaborative decision of when to go. I think that's incredibly important. But I hear what you're saying. You don't want to go to transplant too early because you're right, transplant has its own set of issues and problems. I will add, though, that at least in New York, the UNIS criteria for transplantation recently changed, very recently changed, and because it was a lot of the getting transplants for our congenital heart patients was much more challenging, but they changed in favor of congenital heart patients. So we'll see if the proof will be in the pudding, but hopefully congenital heart patients will have a little bit easier time getting listed or higher on the list because they don't always have the usual criteria of LVAD and, of Swan-Ganz sitting in the unit with 2 pressors. So it made it a little bit more lenient for them.
I will say another kind of word of advice is to establish a hepatologist at your institution and have that person be your Fontan hepatologist because most hepatologists don't really understand this and don't have time to learn it, but maybe if you have one person who does, and fight the urge to just biopsy everybody because everyone's going to be abnormal when you biopsy their liver. And so if you're going to get that data but then not do anything about it, there's no point in getting it.
Yeah, so we probably should, I think we're supposed to wrap up, but the one thing I wanted to say with regard, just a final word with regard to the referral for transplant is that is something that's the subject of ongoing research and there should be data on that soon.